So thank you very much for the invitation to speak about incontinence-associated dermatitis and a tool that has recently been developed and launched. I should say that this is not entirely my work. Most of this work has been done by Dimitri Beekman and Karen van der Bussen. Karen is a PhD student at the University of Ghent, and Dimitri, you might know him. He's a professor at the University of Ghent, and they have the Skin Integrity Research Group, and they did most of this work. So they did this project. I was involved in it, so I know about it. That's why I'm presenting here. But all the honor should go to them. That email or that web address is very important if you want to look up the IAD tool. So it will appear again later, but it is where the IAD tool is available. So how did it all start? Well, actually, this whole journey, this journey started, I think, almost 20 years ago with classification of pressure ulcers. So at that time, Tom de Floor, who was at that time professor in Ghent, and we worked on classification of pressure ulcers and how reliable is this classification. So we took the EPUAP classification system and we asked a lot of nurses around the world to look at pictures, the pictures that we took, photographs that we took of pressure ulcers, and we asked them to categorize them, to say whether it's a category 1, 2, 3, or 4, or whether it was a moisture lesion. That's what we called it at that time. And the results were actually quite shocking from that study. So what it showed is that, so on the bottom you see the correct classification. That is what the experts thought the picture represented, what was on the picture. And on the side, you see the classification by the nurses that we showed these pictures. And what you see is that most of them classifications went all right, those large bubbles in the middle, but there were a lot of mistakes. And when you look at the green ones and the orange ones, there were a lot of mistakes in category 1, which at that time we still called grade 1, so this is really old research. And IAD, which was at that time called moisture lesions. But we saw that there was a lot of misclassification, grade 1, grade 2 also a little bit, and IAD. There was a lot of confusion. So we decided that, that we needed to improve on that, and we developed PUCLAS 1 at that time. PUCLAS 1 is a tool that can help you classify or teach you to classify pressure ulcers and how to classify pressure ulcers. PUCLAS 1 has been outdated. PUCLAS 4 is available now. So if you go to that SKINT website, that PUCLAS 4 will be available there. You have to subscribe to access it, but it has developed since then. But PUCLAS is actually about pressure ulcer classification. It's not about incontinence-associated dermatitis. So this is a very, very short summary of PUCLAS. So what we did is we asked a PhD student did her PhD on showing pictures to experts and asking them to think out loud about what it is that they saw, whether it was a pressure ulcer or an incontinence-associated dermatitis, and why they made that choice. And based on that those thinking aloud sessions, we decided that cause, location, shape, depth, necrosis, edges, and color were the defining characteristics, were the ones on which we based our diagnosis. So incontinence-associated dermatitis, of course, the cause would be moisture and friction, whereas in pressure ulcers it would be tissue deformation. So this is in a nutshell actually what you would learn when you do the PUCLAS training. Of course, there's much more to say about this, but this is where it all started. And Dimitri did his PhD on this, and so the papers are below, the papers he published on this. But as I said, it said nothing about incontinence-associated dermatitis. So what is incontinence-associated dermatitis? Well, it's a specific type of irritant contact dermatitis caused by prolonged contact of the skin with urine and feces. And it's characterized by erythema and edema of the perianal or genital skin. And the skin, the epidermis can either be intact or damaged. And you could see vesicles or bullae, I always struggle with that word, papules or pustules, erosion, denudation, and secondary skin infection. And it causes great discomfort. It causes pain, burning, and itching for patients. So this is what we think incontinence-associated dermatitis is. Question for you, do you see this in practice? Who sees this in practice? Wow. Do you see it once a week? Once every 2 weeks? Once every month? Every day? Every day, yeah. It's a huge problem. And it's been mixed up with pressure ulcers a lot. And it's not a pressure ulcer, and the treatment and prevention should be different. So that's why we started this work on PUCLAS, because we really think that if you start giving repositioning patients with IAD, the IAD won't go away. You have to do something about the incontinence, and you have to protect the skin barrier there. So the prevention and treatment is different. So the etiology of IAD is very complex. So urine, feces, a combination, or even washing with water and soap will cause maceration of the skin. It will cause chemical irritation, physical irritation. It will cause changes in the pH. The pH will go up of the skin, which will increase skin permeability. And that will cause a weakened skin, and together with friction, you will probably find yourself in a position where the patient develops IAD. So there are a lot of things that cause IAD. So for prevention and treatment, but prevention, of course, managing incontinence is extremely important. So prevention and treatment are mainly the same measures, like in pressure ulcers. When someone has a pressure ulcer, you reposition, but when you want to prevent a pressure ulcer, you also reposition. Same goes for IAD. So managing incontinence is very important because that takes away the cause, but also implementing a structured skincare regimen, where as we in a Cochrane review we described, you need to cleanse the skin, so you need to remove the urine and or feces. You need to protect the skin to avoid or minimize exposure to urine and feces and friction. And where appropriate, you need to also restore the barrier function of the skin. So in a nutshell, that's the treatment and the prevention of IAD. Now when we look at prevalence, it's all over the place. The figures say 5.7% of the patients have IAD at a certain point in time, up to 27. And incidence is 3.4 up to 50% of the patients. That's patients who develop an IAD while they're in your care. So prevalence is the number of patients that have an IAD. Incidence is the number of patients that develop it. And it's not so strange that these figures vary so much, because this is what you could see in practice when a patient has IAD. And how do you then say, well, this is IAD, this is a pressure ulcer, and if it's an IAD, how do you then classify that? How do you categorize that? And that's where the Globiad comes in. So there are tools to assess whether something is IAD or not, because if you want to report on IAD, you need to know that it is IAD. So some tools have been validated, but their use in day-to-day practice is rather limited. They are time-consuming and complex to use in clinical practice. So here you see three instruments that have tools that have been validated, but they're very difficult to use. So in 2015, an international expert panel proposed a simplified IAD severity categorization tool with 3 categories. They said there is 0, category 0, no redness and skin intact, so that patient would be at risk if they are incontinent. 1, red but skin intact, and category 2, red with skin breakdown. Now this was, of course, made by experts, so people who knew about IAD, but it hasn't been validated. So what we said, well, validation is needed. And that's the Globiat project that has been done. So this is actually the first crude tool that we developed. It's, and it shows you a perfectly intact skin, healthy skin, as category 0, and then category 1 and 2. So how did we go about validating this? Well, this actually was developed in 2 phases. In the first phase, the instrument design and the content was validated. And for that, we organized a Delfy panel with 34 experts. And a Delfy panel is actually a panel that looks online at the information that you give, and they vote about whether they agree or not, and they are allowed to give comments, and that those comments and those votes are then looked at again by the researcher. They make a second version of an instrument, they send it out again, and in this case, we did 3 rounds. We looked at the purpose and the structure of the categories, the purpose of the tool, definitions and diagnostic criteria, and we asked for additional comments. So in 3 rounds, we were able to develop a new tool, which the experts agreed on. And then came phase 2, because we wanted, like we did with the PUCLAS, we wanted to see how well this tool helped nurses to diagnose incontinence-associated dermatitis and also differentiate between the different stages of incontinence-associated dermatitis. So for that, we looked at inter-rater and intra-rater reliability. Inter-rater is, if I look at something, do I see the same thing that Louisa sees? And intra-rater is, if I show you the picture once and I show it to you after 2 weeks, do you diagnose it in the same way? So how consistent are you in your diagnosis? 34 photographs, an online survey. It was translated into 14 languages. And as I said, the people were asked to rate the pictures and compare it. And then we compared it to the expert rating. We compared between participants with a 1-week slot for the intra-rater reliability. So the results from phase 1, this was the Delfy round. We reduced the number of purposes of the tool. So we said this tool is there to create an internationally agreed description of incontinence-associated dermatitis and to standardize the documentation for clinical practice and for research purposes. So that's what this tool is about. Category 0 was deleted because absence of a disease is rarely classified. So the expert said, well, lose category 0. And an addition of subcategories was done with signs of infection because the expert said, well, infection is actually a very important issue in incontinence-associated dermatitis, and it asks for an extra treatment if you see that. So we would like to classify infection as a separate category. So this is what it looks like. Now, I know you can't see this, but this is available online, and I'll go into the bigger pictures in a minute. But what you see is we've got a category 1 and a category 2, and then the category 1 is divided into without clinical signs of infection and with clinical signs of infection, and the same goes for category 2. So category 1 is defined as persistent redness without clinical signs of infection. And it says that the redness can have a variety of tones. Patients with darker skin tones, the skin may be paler or darker than normal or purple in color. And there are some additional criteria. So there's a marked area or discoloration from a previously healed skin defect, shiny appearance of the skin, macerated skin, intact vesicles or bullae. Skin may feel tense or swollen at palpation, and it's burning, tingling, itching, or pain that the patient feels. So category 1B is the same thing, but there are signs of infection. That means that white scaling of the skin, suggestive of a fungal infection, or satellite lesions, pustules surrounding the lesion, suggesting Candida albicans, fungal infection, might be present or are present. So when you see those, that's when you say there is an infection present. It's a 1B. Category 2A is skin loss without clinical signs of infection. So here the skin is broken. So category 1, the skin is intact. Category 2, the skin is broken. So skin loss may present as skin erosion or denudation or excoriation, and the skin damage pattern may be diffuse. This as opposed to a pressure ulcer where it's not that diffuse. So that's, again, to classify between pressure ulcers and IAD. Persistent redness, actually the same criteria as in 1, so I'm not going to read them all out, but they're the same, except that here the skin is broken. And in category B, the skin is broken, but there are also signs of infection. So again, the scaling of white scaling of the skin, maybe slough in the wound, green appearance in the wound bed, excessive exudate levels, purulent exudate, or shiny appearance in the wound bed. So that's when we say it's a 2B. So this is really nice, and we could start using it in practice, but how accurate is it? So that's what phase 2 of this study was about. So, as I said before, 34 photographs. It was sent round to 823 participants from 30 countries, 14 languages. These people were asked to rate these, to categorize these 34 photographs and to say whether they saw a 1A, a 1B, a 2A, or a 2B IAD lesion. The overall agreement was 0.55, which is reasonable. But when you look at the differentiation between categories 1 and 2, so between just redness with an intact skin or a broken skin, actually the overall agreement was very high, and the sensitivity was very high too, 90%. That means that in 90% of the cases, the patient who was diagnosed with IAD, I always have to think about this, actually had IAD. And specificity is the opposite, and that was 84%. So this actually categorizing between 1 and 2 was very, very good. Not so much so for categories A and B. So identifying infection is a bit more difficult. Interrelator reliability, so do we agree on this? So you see the same pattern, and what we must say is that it was higher for more experienced and more educated clinicians. So the more training you have, the better you are at this. Intra-rater reliability is, again, if you see it after a week, do you give the same diagnosis? So 463 participants looked at the pictures again after a week, and it was intra-rater agreement 0.71 for all categories, and again, differentiation between category 1 and 2 was higher. So it does help us identify a difference between category, is it a category 1 IAD or is it a category 2 IAD? So the conclusion is that content and face validity is supported, 100%. There's a high degree of diagnostic accuracy for distinguishing between intact but erythema skin and skin loss. There's a lower degree when assessing clinical signs of infection. And there was a discussion in a paper about should we consider an additional swab maybe, but that of course is very expensive. Same goes for the reliability, by the way, that the reliability is less in identifying clinical infection. So I think what we are saying is education is very important. So like in PUCLAS, we need to develop a training pack, and we need to start training people or getting that available to you so that you can train yourself and your nurses in making this distinction, so that we can then report on pressure ulcers and report on IAD and be fairly sure that the figures that we present, that they are correct. So the Globiat tool is available in 14 languages. The English version is available, well, so look at skingent.be or skingent.com. You will find it there. And the British Journal of Dermatology published a paper on how we developed this tool, with a lot of authors on it, because a lot of people helped collect the data. that's the next presentation. Thank you very much for your attention. Are there any questions?
Can I just ask, it's a shame that it refers to categories. So when you're trying to make a distinction between pressure ulceration and sorry, for those of you who didn't hear, is this on?
Yeah.
It's a shame that you refer to the categories and categorisation. Of now the NHS Improvement have determined that we review pressure ulcers and classify them as categories and refer to them by that terminology. Staff really, as your first slide showed, really struggle with pressure ulcer classification and categorisation, and now asking them to think of Cat 1A, Cat 1B, the documentation of that, instead of making a distinction, can cause more problems.
Okay. So what would your suggestion be?
Maybe different terminology and not using the phrase category or level, or just using, different descriptors, or the descriptors, but using different annotations for it, because now we have to put medical device related injuries and annotate with a D. So actually by the time you've written up your notes, you're on your second pen by the time you've put all your annotations in and categorizations.
Okay. I think it's a good suggestion. I don't think we've thought about this, so we use the word category for pressure ulcers and for this because it's not a linear scale. So that's why we prefer the word category. So because you can have, as with pressure ulcers, you can have a category 1, for example, and then go to category 4, and you don't necessarily have to see a 2 and a 3 in between. So that's why for pressure ulcers we chose that, and the same actually goes for the IAD. But I'll tell Dimitri, and I'll discuss it with him. Yeah.
Any other questions?
Any other questions?
I have a quick question. Oh, sorry, go ahead, this lady.
Have you looked at...
Hang on a second, just the mic.
Have you actually looked at what you can actually use? What products? Have you got any recommendations for prevention or treatment?
No, so there are a lot of products out there, and there is no study looking into these are the really good ones or these are the really bad ones. So I can't give a recommendation on products, just purely because I haven't done any research on that. But maybe if someone here in the room has good experiences, maybe you can share after the presentation what good products are. I think I think there are some. So it has to protect. It has to form a barrier. Dimethicone is a substance that works very well for that, but there has not been a comparison of products. So unfortunately, I can't. And there's a lot of them out there, so it's difficult to choose. Yeah.
One final question, this gentleman. Just right there. Yeah. Just hang on for the mic, please. Thank you. Just wait.
No.
Actually, I have a stupid question because I'm very new in into development, and traditionally we use a consensus method approach based on the Delfy method to develop a diagnostic tool. And recently there is a development in using prediction modeling, and there is a strong team in Utrecht Medical Center led by Carl Mons. Yes,
Yeah.
They try to use modeling methods to based on the baseline characteristics to predict how probability the people will have the outcome we see now. So my question is, what's the original driver for you to using consent approach to develop these two rather than the modeling methods?
Yeah. So the modeling method would be about who will develop an IAD. So you would take the risk factors and based on that develop a model that could predict who would be at risk or not at risk. This is about diagnosing, so about saying this is what it is. So this is a category 1, this is a category 2, and a prediction model would not fit that kind of question. So I understand. So when you for example, you would develop a Braden scale for incontinence-associated dermatitis, or which is a prediction tool, that method would be very good. But this is really about in clinical practice, can we see the difference? And it's not about predicting whether someone would get it or not.
Sorry. But in practice, we do have a dilemma, I think. When we see a picture, we cannot really sure that's category 1 or category 2. We can only guess the probability how probable the picture is at category 1.
Yeah.
So in my sense, in my mind, I think probability approach might be more useful than that one in practice.
You mean for the diagnosis of the condition?
Yes, we can only know the probability rather than whether this is truly.
Yeah. And I think that I will look into that because Carl is my colleague, right? So I will discuss it with him and see whether this is an option for this tool for diagnostics. But for now, we chose to first make these pictures so that everyone in clinical practice could easily use them, and then maybe later we can make it more sophisticated with a diagnostic model. Yes, thank you.
That's lovely. That comes to the end of our session. I'd like to thank our two speakers. And